All right. So if you're good with vital signs, I'll skip that part. Yeah.
I'm just confused.
Wait. Ask your questions at the end.
Okay, yeah,
Okay. Ask your questions at the end, so I can get through it. And then the lungs. What we're going to do is, here's your routine. Your Bible here. This guy. I demonstrated this for you for lung and thorax. True. This is what you now work off of. All right. So you go to this guy, and that's in your notebook. Do you agree? This is the long play, right? This is the lung and thorax long play. All right. So this I will redemonstrate. Should I do cardiac first? I think I should do cardiac first. Let's go do cardiac, then we'll come back to lungs, all right? Cardiac. The general parameters, appropriate relationship to S1, rate, rhythm, strength, and the extra heart sounds. You've got that, right? Structure, assessment of parameters. Precordium, we will have the patient, and I think we'll bring someone up and have them do this. So number one, patient. Come on up here and lie down for me. We'll put the head down here. And I'm going to inspect, and when I inspect the precordium, now we're cheating, guys, right? She's got a gown on, true? Yes?
Yeah.
Hey, would someone run and grab me a gown off the shelf as soon as you walk into the clean utility or the lab there? Yeah. And pull a gown off of there. We'll have you use this gown so it looks more real life. I don't, again, when I'm inspecting, look up here. This is all I can see, and that's good enough. I don't want you doing that kind of thing, okay? So we'll inspect there, and once we get the gown on. Inspection is looking this way, and it's also sighting across the precordium to see if you can feel any heaves. Sit up there with that gown on, please. Thank you very much. All right, so we're doing this, and this is polite. Do you agree? Right there. So we inspect across there, and as we look across there, I'm looking for, what are those things when they go up like that? The medical vernacular, pulsations, but they're also called heaves or lifts, right? So I'm not seeing any heaves or lifts from what I can see of the precordium, and I'm just looking at whatever I can find there. Now, if you're following along with me, we've got, you want to palpate and find the locations for the auscultatory sites. And how we start with that is in the sternal notch. Remember that? We come down and we find the articulation of the manubrium with the sternum, and we call that the angle of Levy. And I come over and I find that second rib, and then I find the second intercostal space. And I jump over to the other side, and I find the second left intercostal space. And then what side is that, by the way? That was the aortic, and now we're moving to the pulmonic, third rib, and third intercostal space. We call that the Erb's point. Fourth rib, fourth intercostal space. We call that fourth intercostal space. Then the fifth rib and fifth intercostal space, and here I am right here, and we call that tricuspid. And I work my way over here, and I find this guy, and that is the mitral. Okay? Now, you can combine these steps. I split them up. You can combine them if you want, which is come right back now. I know where to palpate. I know where to listen now. So I come right back to that area, and I'm in that aortic auscultatory site. I'm palpating for any pulsations. I don't want to find any pulsations there. If I do, it means it's an enlarged heart, some congestive heart failure. No pulsations, and what do I do now? I'm going to check for thrills. What do I do now? Put the palm of the hand down like so. No thrills. Over here, no pulsations, and look what I do. Little fancy maneuver. I catch it with the side of my hand. Is that polite? Yes. So pulmonic, no pulsations, and no thrills. Erb's point, there it is. Pulsations, negative. Thrills are negative. See that side hand thing going on there? That's really polite. Fourth intercostal space, negative for any pulsations, and negative for any thrills. The fifth intercostal space, that's a tricuspid. I'm assessing for pulsations, and they're negative. Is that what you want? Yes. Thrills, negative for those. Now I come over to the mitral, and pulsations. Should I feel pulsations there? Yes, you'll find pulsations there. So for the PMI, the pulsations, yep, and look at the PMI thing here. It says palpate the PMI. Location is in the fifth intercostal space, midclavicular line. The rate, as I'm feeling it, it is very consistent. I don't expect you to do this and redo that, but the rate is consistent with what I got on my vital signs when I check my pulse. So what do you say about the rate? Consistent with vital signs. You with me on that? And rhythm should be regular. Intensity should be fairly strong, right? Intensity strong. Diameter should be just in that fifth intercostal space. That's the only place I feel it. I don't feel it anywhere else but the fifth intercostal space. Does that sound right to you? So diameter, just in the fifth intercostal space, and the duration is short. It's like a very short tapping. You felt that a couple weeks ago on yourself. It just feels like a little fine, short tapping. It's strong, but it's like a tapping. And so duration is short. Then we move to listening, and that's with the diaphragm for the first 2 times, and then with the bell. And if you look at your notes there, that first time through, what do we look? Look at your notes. What are we doing? We're identifying the appropriate relationship with S1 and S2. So stethoscope, and I'm going to tuck this under your gown, okay? Tuck under. Look how I'm controlling from the outside. I'm not reaching into her gown. And here's your aortic. One dub, one dub, one dub. Listen to a few there. Move over to pulmonic. One book, one book. Listen to herbs. Listen to the fourth intercostal space. Tricuspid. Couple baby steps. To the mitral. I do have the appropriate relationship with S1 and S2. I stay right there, and now I work back. A little step. A little step. Tricuspid. Fourth intercostal. Herbs. Pulmonic. And aortic. And I did not hear any high-pitched extra heart sounds. Now we're going to switch over to the bell, and we press lightly in those areas with the bell. You don't want to press too hard because you make a second diaphragm out of skin, and you're picking up high pitch again. So lightly, aortic, pulmonic, herbs, caught. There we go. Fourth, tricuspid, couple baby steps. To mitral. And I heard no low-pitched extra heart sounds. Now we come, and don't smack your patient in the chin with your stethoscope as you bring that out. And I need you to switch off. I kept you way too long because I got all involved. Let's see. So, with the diaphragm, first time through, there was the appropriate relationship with S1 and S2. With the diaphragm the second time, I didn't hear any of those high-pitched extra heart sounds. With the bell, I did not hear any of those low-pitched extra heart sounds. And if I did hear a murmur, I would tell you about the high intensity pitch carriage, location, maximum intensity, and radiation, all that stuff. And then can I have number 2 patient? Who's number 2? How do you put the gown on? And I'm going to show you percussion on the accordion. So much. Yeah, if you would, please. When you're working off the heart, guys, it's best to go to the right side of the heart if you're right-handed. If you're left-handed, left-handed. look what I can do here. Does that look right? And if you're going the other side, it's kind of strange, you know, the whole configuration. So we've got the sternal notch, the manubrium, second rib, second intercostal space, third intercostal space right here. So we're going to go right in the midclavicular area, and I'm percussing through some layers here. So let's see what we get. What should my note be? Do you have it? Dullness. Hear more of that thud thud. Real thud thud. Starting to come back. That's your collar right there. Back to resonance. Okay, so resonance, dullness, resonance is what you're getting there. Did you hear that in the back? Grace, did I pass? Did you hear the sound? Then I pass. Okay, good, thanks. All right, so that's the cardiac there, and respiratory. I showed you respiratory already, but I'm going to show it to you real quickly. Is that a good idea? Real helpful? All right, so third, who's my third person for respiratory? Come on up and put a gown on. Actually, you've got a gown on. Let's, I think you basically have a gown. You guys agree? I mean, that's a lot of layers. And I have you sit up here.
It's cold in here.
Yeah, I just have you sit up here. So for the skin, and I'm going to stand off to the side here so you guys can see what's going on, as opposed to this is where I should be, right? So skin, now what should we put on? Inspect, color is appropriate. Oh, she's looking a little bit pale, wouldn't you say? Appropriate flesh tone, temperature with the back of the hand is appropriate warmth. She's warm. Moisture is appropriate moisture. She's not sopping wet and she's not dry and chafing. Texture was smooth. Lesions, negative for what I can see. Bony structures, inspect and palpate. We want to look at the general size of the thorax, the shape. Size is appropriate. Shape is appropriate from what I can see. Let's see on inspection. Now we palpate. So palpation, checking the clavicles, checking the sternum. I go clear to the xiphoid process, and so that looks all symmetrical. And any retractions? I did not see any retractions. Ability to shrug shoulders. Did I show you this? Did we skip over that? I don't remember shrug shoulders. Did I show you that? This is where you have the patient. Give me a shrug. That's where you have a shrug, and if their muscles in that thorax is okay, you get a good strong shrug on each side. If they if they have any stroke, the affected side will be kind of weak there. Let's see. And any retractions, and I did not see any retractions. Clavicles. I jumped ahead of myself. I already palpated. I inspected. I palpated. Respiratory excursion. I'd like you, when I put my hands on the lower part of your chest, you ready? When I put my hands on the lower part of your chest, I'd like you to give me a turn that way, by the way. No, you're just your head. Sorry about that. Just your head. So come up here, and I'd like to give you a big, deep breath in now. Okay? And make sure your hands are on the thorax, and you're not like this, but you really have your hands on the thorax. One more time. Good. Respiratory excursion is deep and symmetrical. Let me catch up with myself. Lungs. Now I want to listen. Can I use this as my gun? Is that okay? If I drop my stethoscope underneath there? Okay. Now I'd like you to breathe deeply through your mouth and a little quicker than normal. You ready? And I'll have you turn that way for me. Okay. First one. I'm ready when you are. There we go. Good. I don't know where to stand, guys. If I do that, is that better? 2. 2, 3. Don't reach into the gown. 3, 4, 4, 5. Sorry, excuse me. 5. Good. 6. And 7. That's the anterior. Make sense? Does that make sense? Okay. And then breath sounds. The rate, this is how I'll describe this. The rate was consistent with what I got on vital signs because I already looked at the respiratory rate. I don't expect you to redo the respiratory rate with this thing because you're having to breathe deeply through your mouth. You follow me? So the rate was consistent with vital signs. The rhythm was regular. The depth was deep because I asked her to breathe deeply. Effort was non-labored. Use of accessories was negative. I didn't see any of that. And there were no extra lung sounds or no adventitious breath sounds. And if there were, I'd describe them to you. Let's switch out. Let me take the next patient. Who's not, is it on my on 4? Lateral. Real quickly again comes on. It's screwed up, but that's fine. Lateral. The see, and lateral, we just take the gown, and I don't expect you guys to go like this, all right? Just take the gown, take a little bit side there, okay? That's nice and polite. Take the gown and look a little bit onto the side there, and she's a little bit cyanotic. Look at that. So the skin is the appropriate flesh tone and negative for lesions, and I don't expect you to listen to the laterals. That's completely optional. Posterior. Take a look at the skin. Color is appropriate flesh tone. I don't see any lesions. We can listen to the breath sounds, and I'd like you to give yourself a big hug. And yeah, there you go. Thanks. Big hug. And oh, God, I wouldn't do this to my 80-year-old lady, but can you put your legs up and spin around here and go the other way? We would not do that to our 80-year-old lady. We would come around the lady. You guys need to see. Come this way for me. I'm short. I have to be able to reach. All right, now give yourself a big hug. And so C7 off the side. And I like you to breathe deeply through your mouth, but no quicker than normal. And see how I'm stabilizing her. You can do this or you can do this. I prefer this. All right, a couple deep breaths whenever you're ready. There's one. One. 2. 2. 3. 3. 4. 4. 5. Good. 5. 6. 6. 7. And 7. Does that make sense to you guys? Look good? All right. Let's see. Posterior color. Listen. What did I do? Did I jump ahead? No, I didn't. I'm good. And then spine scapula. We want to look at the shape of the thorax and symmetry. Shape is appropriate. It is symmetrical. Let me check the bony provinces. The scapulae hitting at the same level. The cervical, thoracic or dorsal, lumbar, and sacral, all straight line. And then can I just have, you can unhug yourself now. And can you sit up nice and straight for me? And now I'm looking at the appropriate S curvature of the spine, and I do see that. Curvature of the spine, got it? And respiratory excursion. I'm going to put my hands on the back again, okay? Ready? And I'd like you to take a deep, let me do it this way. Take a deep breath. Good. And respiratory excursion is deep and symmetrical. And lastly, on this thorax, lung and thorax, I'm going to check the AP versus transverse diameter. And pledge of the allegiance, back here on the scapulae, and I bring that around right up here. And is that about, a little over, but is that about 1/2? That's what, notice I didn't do this. Notice I didn't do that. Don't do this. That's not the thorax. This is the thorax here. So AP versus transverse diameter. You with me, guys? All right. And good. Thank you. That will. Sorry that I manipulated your time a little bit too much on this end. Now, your questions. What do you have for me? Does that all make sense?
Will you be asking us?
Oh, wait a minute. Hey, what was my name?
You never did.
Didn't I say Dr. Harris? Did I talk about that at the beginning?
You did, but you didn't do it.
Yeah, but I didn't do it there. Okay, so Dr. Harris. So, in terms of your report, hang on a second, guys. In terms of the report, I didn't do that part. I have a 20-year-old Caucasian female, I'm guessing, who is in her appropriate height and weight, grossly a good BMI down there. Dress, grooming, and hygiene are all appropriate. Mental status, she is cooperative, she's animated, logical thought pattern, articulate speech, she's alert and oriented times 3, recent and remote memory are intact, abstract thinking and judgment are intact, temperature, pulse, respiration, and blood pressure, and pain, I would give you the values there. I would tell you that the lungs, I saw no suspicious lesions. Color, temperature was all appropriate. Color was appropriate, flesh tone. Temperature was warm. Moisture, appropriate moisture. Texture was smooth. Negative for lesions. The size of the thorax was appropriate. I kind of gave that to you as I went, I think, didn't I? Did I tell you this? So I won't repeat that. You may do it one of two ways. I think I gave you the findings for the rest of that, all the way through. You can give it to me as you go. You can tell, you don't have to look at me. You don't have to make eye contact or anything like that. You can just say, I'm fine with my 20-year-old Caucasian female is presenting with, and then you just go through like you're throwing up and I can hear you. Now, there's going to be 2 people in the room doing an examination at the same time. So you cannot wait for me to listen because I'm listening to both of you at the same time. Do you follow me? It's going to be more confusing to you than it will be for me. But should you be able to do an examination amidst distractions? Absolutely. So you conduct your exam. I'll get up and move around. I'll watch. I'll look. I'll do all that stuff. You talk as you go. Or if you want to, just do the whole examination. And when you're done, come through and look at the parameter or the parameter and give me the descriptor that goes with that. Appropriate flesh tone, negative lesions, all that kind of thing. Am I making sense to you guys?
Yes.
So you can report as you go, or you can report at the end. And at the end is when you have to tell me, well, it looks like I have an appropriate, well-nourished or vigorous Caucasian female, appropriately dressed, grooming, all that stuff. Just go through the list there and tell me how that is. And then I already reported my findings for the respiratory and the cardiac exam to you, as well as the vital signs. Does that make sense? Questions now?